we have to deal with calcium in different parts of our body, and this is really a difficult issue, and we are limited with what we have in our hands so far to treat calcium in an efficient way. You see here CT images from calcified vessel areas pre-IVL and post-IVL treatment, and you see with the areas the cracks in the calcium. And what was really amazing for me when I used this technology first, seeing that the vessel compliance is really increasing and that there is no distal embolization, which I could not imagine before. The Shockwave M5 Plus catheter gives us broad access options with increased catheter working length of 135 centimeters, and it's larger because we can also treat vessels up to 8 millimeter, and it's faster. It increases the procedural efficacy. We have data out there in the peripheral field that this technology is really showing a great, exceptional safety profile. You see here in the district bed 3 RCT and then also in the observational study, really nearly no dissections, no perforations and no distal embolizations. And the acute outcome effect is really amazing when you look at the pre-procedure stenosis and the post-IVL stenosis and then the final stenosis. So this is really an efficient and safe tool to treat vessels. So calcium is still the Achilles heel of IVD, but IVL is sufficient to overcome the challenges.
We all know that hostile calcified access is an exclusion criteria for EVAR-TEVAR procedures, and those complications are always associated with both perioperative and, of course, long-term morbidity and mortality. So we all know the PARC classification, but let me introduce you a new type of hostile access criteria. We have the mild one, we have the moderate, as we all can appreciate, and then we come to the severe and the concentric ones, and these are the hostile, which provide the hostile access, especially if the MLD is less than 7 millimeters. So when should we use IVL? When we have an EVAR, when we have a patient requiring EVAR, if it's an eccentric stenosis less than 5 millimeters or concentric less than 6, in FEVAR, BVAR or TVAR cases, when it's eccentric less than 6, or if it's concentric less than 7 millimeters. So it's very important before starting your procedure that you accurately check all lesions. So don't compromise on graft selection. When I have a patient, he has narrow vessels, I order a low profile endograft. When I have his normal vessels, I use a standard device. Calcium doesn't bother me anymore with this new technology. So I have two examples for you. This was a 71-year male patient with a large aneurysm at the arch, and the plan was to implant a thoracic endograft with an in situ fenestration for the left subclavian artery, a 20 French device. And these are his access vessels. On the right side, he had a 6 millimeter self-expandable stent, so we could forget about this. And on the left side, we have this heavily calcified external iliac artery with an MLD of 5 millimeters. So this is an image over a 14 French sheet, and then after that, the 8 millimeter was not yet available, unfortunately, but I used a 7 millimeter IVL catheter. First go up to 4 atmospheres, so very low pressure to really crack your calcium to change vessel compliance, and then go up to 6 atmospheres, and then I was able to advance first of all a sheet and then the endograft itself, and I was able to finish the procedure without any problems. Here's a short video where you can see the IVL working, first dilating to 4 atmospheres and then going up to 6 atmospheres, and then of course after that there was no problem to advance first a dilator. Before I unpack the more expensive device, I first check with the dilator that I can pass through, and then you can see how smoothly the endograft could go over. So these are very exciting images, I think personally. You see pre and post IVL treatment. You see the luminal gain going from 5 to 7.7 millimeters. The last example is a 77-year-old female patient with a type 3 thoracoabdominal aortic aneurysm. Plan, of course, was to do a low-profile BVAR, access with the right femoral and left axillary artery. As you can see in my drawing, she has always those stenosed hypogastric artery, stenosed iliac arteries on both sides. As you can see again here on the CT scan, the right side was the more accessible one. The left side had a very tight, narrow, calcified common iliac artery stenosis. So I went from the right side, as you can see in these pictures in this video here, where you can appreciate the heavily calcified axis. This is the 8mm device, which was then available. We were very grateful for. And we treated the entire iliac axis, which was necessary. And after that, you can see how smoothly we were able to advance our endograft. This is the image after IVL treatment. And this is amazing how we, without any problems, without any pull-through wires, can advance our endograft. This is the tight stenosis on the left, also heavily calcified, so I opted to go here from above, from an axillary approach. You can see the catheter struggling, going through it. So after IVL treatment, I was able to advance my sheet without any problems, and I attached it with a balloon expandable covered stent. I treated the entire iliac axis as well. She required stenting in the external iliac because she was also a PAD patient, and afterwards the ABI index increased on both sides. And these again, pre and post images of both sides where you can see the luminal gain and the perfect outcome.
And if we look at the vessel preparation methods we got, then PTA is no more than pressing the calcium inside healthy tissue, so the calcium mostly stays the same. And atherectomy and calcium is difficult. If you do an unidirectional atherectomy like Hawk, then usually you skip from the calcium to the healthy tissue, unless you use Panteris, for example, where you can see where you cut. But if you use the Hawk, which I use a lot in non-calcified lesions, then you skip from the calcium and you cut inside healthy vessel, and this is not the solution. Scoring PTA and, for example, non-slipping element PTA works with lower pressure, but the principle is the same. One advantage is that you cause longitudinal dissection and not this diffuse dissections, and so it's not that flow relevant. In IVL, we apply highly focused ultrasound, and PTA or dilatation of the vessel is not the principle. So if you look at this case, you can see a heavy calcified common femoral artery in this woman who refused surgery. And this is the result after PTA. So you can see there's still flow-limiting calcium in the origin of the SFA. But if you treat this lesion with IVL, you can see here at 4 atmospheres, I didn't rise the pressure. I stayed at 4 atmospheres, and you can see that the balloon of the IVL device opens up. And when you see in the cadaveric SFA, in this case, you cause cracks inside the calcium, leaving the rest of the vessel, in this case here, healthy and undamaged. So if you do IVL in this case, you get this result. And you can see the calcium, but it's not flow relevant anymore. IVL is a safe, easy, fast and predictable method. If you have a resident that can do PTA, he can do IVL, but it's not said that he can do atherectomy. So this is very fast and easy procedure and low complication rate, a steep learning curve. You leave really nothing behind, and we have so far very convincing data.
Another disclosure, I spent far too many hours in my life picking out embolus from tibial arteries and trying to get aortic endografts of calcified iliac vessels. So what are the hurdles for endovascular therapy in calcified CLTI? They're the intraprocedural hurdles of flow-limiting dissection, distal embolization, acute recoil, and a very high risk of bailout stenting. Often in CLTI patients, you have a suboptimal runoff, and I don't like to be forced to stent when I don't want to do that as a primary procedure plan. Post-procedure, we're at risk of subacute recoil, poor uptake of anti-restenotic drugs, and managing in-stent restenosis when we do have to stent in a difficult situation. So let me show you some cases here. It's very rare you get the opportunity to control your own work in the same leg and the same lesion, but this is a 59-year-old patient who presented to us first in February 2019 with rest pain in his left foot and a few small ulcers. He's a type 1 diabetic, and he's had a renal transplant before. You can see the amount of calcium here on the angiogram, and you can see this kind of focal, tight calcified stenosis. What did we do in 2019? Well, we crossed the lesions, and we used a rotational atherectomy and did a plain balloon angioplasty, a drug-coated balloon angioplasty, and what are we left with here? We're left with a filter that's full of embolic material. We're left with trash in the perineal arteries. So you know how this story goes. lots of difficult tibial work, some thromboaspiration, some angioplasty, and finally we managed to get this patient off the table with a decent runoff. The same patient presents to us 2 years later with new occurrence of rest pain in the same foot. He's got a fourth toe ulcer with pus expressed from the wound, and you can see here the disease has essentially recurred in exactly the same place with exactly the same severity, but now we have IVL available. You can see on the intravascular ultrasound pictures how calcified this disease is, and you can understand how this is going to respond to plain balloon angioplasty, and we know how the atherectomy story ends from the previous procedure. So we used the intravascular ultrasound to size accurately for the procedure. As has been mentioned before, it's important to oversize the balloon correctly to get good wall apposition. You can see the Shockwave balloon expanding without any additional inflation, which means that the Shockwave pulses are breaking the calcium and changing the compliance of the vessel wall. We see a plain balloon angioplasty and a drug-coated balloon angioplasty, and we end up with this IVUS image, which shows a greatly improved luminal gain, an excellent flow on the angiogram, and no trash at all in the tibial vessels. I'm feeling very confident. We've got time on our hands. The patient's feeling good, so we move on and treat the tibial lesions as well with the tibial IVL catheter. Again, we end up with this very pleasing result. The clinical story of the patient: his rest pain is gone, the ulcer's dried out, but he has osteomyelitis, so we have to take away the fourth toe, and his fourth toe amputation wound is now healing well. Is the acute result better? The Disrupt PAD results from 30 days suggest yes. Is it more durable? Well, we're going to find out next month what the one-year results from Disrupt PAD 3 trial are. I can tell you one thing: it's definitely less stressful for the patient and for the operator. I'll leave you with one final case. This is a 64-year-old male, diabetic with a necrotic hallux. You can see this focal occlusion in the popliteal artery, as we were talking about before. This is what we call a no-stent zone. I particularly don't want to stent the popliteal artery in a 64-year-old guy who's essentially otherwise healthy, active. I know if I put a stent there, it's going to occlude quickly. You can see the IVUS image, a tightly calcified stenosis. I have to do a little bit of pre-dilatation to get the Shockwave balloon through, but you can see this very, very pleasing result with the intravascular ultrasound and excellent flow on the final angiogram, again, without having to stent, without having to cause a problem to the runoff. So I'll just leave you with this data, which was presented at Viva last year. IVL shows very, very consistent outcomes across multiple vessel beds, lesion types, and specifically in critical limb ischemia patients who are the most at risk and the most difficult to treat. This is making life a lot less stressful for all of us.
We are running out of time, but just one comment from each of you. What are you thinking is the biggest impact this technology has in our daily life? If you want to start, Michelle.
Way less stressful for us. I mean, even if I have heavily calcified access, I have no problem anymore.
Yeah.
For me, one of the most important things is that you can do IVL without jeopardizing any other method. So you can try IVL in calcified lesions. If it doesn't work, you can do all the other tools. You can use all the other tools that you have.
And New Year end for CLDI patients, I think where we really have to preserve our limbs.
I think this has been a whole paradigm shift really for us, right? You know, before you could put a patient on the table, you have some tibial trash, your whole day is ruined, right? You're there for hours trying to fix the damage. The safety profile and really the way you can rely on a consistent outcome with IVL, it's really changed my life.
Yeah.